many of us, because she works just at the Department of Psychiatry. She's actually the associate head there now, and also professor of cognitive neuroscience. I will not say too many words because I think Kath has actually done this short introduction for us of how she's come to where she is now. But her lab is the PERL lab, which works on a lot of really interesting psychological actions of antidepressants. And so it will be of interest and really relevant for many of us here in EP. And we really look forward to your talk, Kath. Thank you so much for coming.
Thank you. Thanks for the kind introduction and for the invitation. It's a great pleasure to be here and lovely to see so many familiar faces in the audience. And so I want to start with a brief description of my career path to date as part of your Themis 1 initiatives, which I think is a great idea, or at least I did until I tried to think of something interesting to say that wasn't just a kind of long list of different roles and appointments. So rather than go through this list, I thought I'd just make a couple of highlights that might be relevant or interesting to some of you. I think one of the largest challenges in my career has probably been making this change between working with preclinical animal models as part of my PhD, working in human psychopharmacology. And this is a really difficult change to make because at the time I was applying for postdoctoral positions with not really the same set of skills that somebody else would have had in my position. I had lots of skills in HPLC calibration and microdialysis and so on, but these were less relevant to the human work that I wanted to do. So I was really grateful to Phil Cowan and Guy Goodwin here in Oxford, who gave me a chance, and they gave me a one-year postdoctoral position looking at tyrosine depletion in acutely manic patients. And this was a really interesting year. I spent the year basically in adult inpatient psychiatric wards, working with patients in an acutely manic episode. So this gave me a phenomenal insight into clinical work, clinical assessments, the human journey that leads people into that kind of situation in the context of bipolar disorder and mood disorder. And it really provided me with a context and cornerstone for much of the work that I went on to do next. I feel I should also highlight, as this is part of your Athena Swan initiatives, that at least the latter part of these career moves were done alongside parenthood. So this was actually when I was a university lecturer in this department here. I think I was the first academic to have maternity leave. During this time I had twin boys here. Good excuse to show some baby photos. And then a few years later I had my daughter as well. And so this was a great opportunity for me to look back through the family archive of photos, because these little babies are not so little anymore and are approaching their 17th birthday. And so I'm going to be talking about antidepressant drug action today. You've probably seen headlines like this in the media over the last 6 months or so. It's become a rather topical area of debate, and it was really fueled by an umbrella review that was published last summer by Joanna Moncrief, trying to debunk the serotonin hypothesis of depression. The idea that low levels of serotonin may contribute or be responsible for depressive illness. And I remember when this review was published, it was during the summer break. I was just about to go on holiday. My phone wouldn't stop ringing and pinging with messages and questions from journalists. And one of the main questions was, what does this mean for people who are taking SSRI antidepressants? Because we don't fully understand the pathophysiology of depression, should we not be using these antidepressants? And I think this this headline from The Guardian here is probably closest to what I think. I think we have moved beyond a simple or a single neurotransmitter theory of depression, but that doesn't mean that antidepressants don't work. And there's hundreds of randomized clinical trials which support their efficacy in depression with a similar effect size to those seen for other treatments in other areas of medicine. But I do think it's fair to say that we don't fully understand the role of serotonin in depression nor why increasing the synaptic levels of serotonin really have such a widespread effect on the many different symptoms seen in this disorder. And so that's what I'm going to be talking about today, linking the pharmacology and the psychology in depression. And so when we think about approaches to depression and its treatment, there tends to be quite different ideas and views which are expressed using different language and different terms, and are often viewed almost as if they're separate, as if they're in competition with one another. And so we've mentioned antidepressants, but psychological treatments such as cognitive behavioural therapy has roughly equivalent effects in the treatment of depression, but tends to get considered at a different level of analysis. So when we think about antidepressants, we tend to think about molecules, cells, synapses, neurochemicals. And when we think about psychological treatments, we might think about thoughts, beliefs, behaviours, and emotion. And so I started as an experimental psychologist. When I came into this area, I was struck by this division and started to wonder what would happen if you looked at the effects of drug treatments on the kinds of processes that were interesting for clinical and cognitive psychologists. And so this is going back quite a few years now, but I started this series of studies looking at the effects of antidepressants on psychological processes relevant to depression, such as this so-called negative affective bias, which I'm sure you're all familiar with. It's seeing the glass as half empty as opposed to half full. And it actually affects many of our cognitive operations, from what we attend to in the first place, how we interpret information, and then what we store in our memory as well. And these kinds of negative biases are seen in depression and are believed to be a powerful driver of some of the experiences. And so I've got a couple of cartoons to illustrate these kinds of negative biases just to kick off. And so I'd like you to imagine you're walking away after the talk across the park, and you see your good friend Joe, very high-tech animation. And to your surprise, he just ignores you. And if that ambiguous situation happens, you might, well, notice that he's ignored you and actually generalize from it. No one really likes me, and in fact, I'm stupid. They didn't like my most recent paper that I published. On the other hand, you walk past Joe, he completely blanks you, and perhaps you don't really think about it at all, because it doesn't really impact you, and perhaps he just needed a new prescription in his glasses and he didn't see you. Another quick example, you're out walking your dog, it's a nice foggy morning, when you feel that awful sinking sensation and you know you're landing in a big pile of dog poo. It's just not fair. This kind of thing always seems to happen to you. On the other hand, with that sinking sensation, you could remember that you almost put your flip-flops on. So actually, it's a really lucky start to the day with your nice green Wellington boots. So these kinds of negative biases have been seen in depression and are believed to play a key role in risk and in maintenance of the disorder. And they're also one of the explicit targets for psychological treatments, such as cognitive behavioural therapy. And there's been less work looking at antidepressant drug treatments, but there is actually robust and growing evidence that antidepressants can also affect these kinds of emotional processes. And perhaps the most surprising thing is just how early you start to see these effects. We're all used to the mantra that antidepressants don't do anything for weeks, and that's because there's all kinds of adaptive processes that need to take place. But actually, you can start to see changes in how people are processing information within hours of the very first dose. And so that gave rise to this cognitive neuropsychological model, the idea that antidepressants can have fast and direct effects on emotional processing, which could then lead to improvements in the symptoms of depression. And so this is a rather different perspective on antidepressant drug action, because it's suggesting that the delay in effects is not because of the need necessarily for neuroadaptive effects to occur, but it's a rather psychological explanation. Once you start to see more positive information and less negative information, you need to experience your own life and interactions with the environment with that kind of different processing style, which gradually over repeated experience and practice will lead to this improvements in mood. And so today I'm going to briefly cover the evidence for this, kind of model, but then I'm going to move on to some of our more recent work where we think about how we can actually use this information, hopefully, to improve the treatment of depression. So I am going to go back to some relatively old work, but I'm going to kind of zoom through it quite quickly so I've got time to go through some of the more recent work as well. And so this was actually the first study that we did looking at the effect of antidepressant drug treatment on these kinds of measures of emotional processing in depressed patients. We know that depressed patients don't report feeling any better until they've taken the drugs for a number of weeks, but we wondered if we would be able to see changes in emotional processing within hours of this first dose. And we use a number of different tasks, and one of them is this facial expression recognition task. So we present photograph faces like this. I put them together in an animation, but actually they'd be presented frame by frame and intermixed with other emotional faces. So it's quite tricky, particularly at the low levels of the face. And so we know that when people are depressed, they find it much harder to see this as a positive affiliative face, particularly at this like subtle level here. And in fact, those positive faces tend to get seen more as anger or disgust, and less so when this is like a very obvious smiling face at the end there. And that's exactly what we saw in this first study, that this is accuracy of happy face recognition in a group of healthy people and depressed people. And the depressed people found it harder to identify this positive type of face. But then here you can see what happens with one dose of an antidepressant compared to placebo, that this happy face perception is enhanced. So these patients didn't report feeling any happier. They were no less depressed after this one dose, but they're already a bit more receptive to this positive information in the environment. And we can also see effects in different cognitive tests, such as an emotional memory test. Here we present these kinds of positive and negative words, self-referent in a self-reference task where you have to decide if you'd like or dislike to be referred to as this personality characteristic. And what we see is that when people are depressed, they lose the memory for some of the positive words compared to healthy controls, less so for the negative words. But then with a single dose of an antidepressant, you can see that memory for these positive words is improved. Again, before there are any changes in subjective mood or symptoms of depression. And these kinds of effects on human emotional processing can be seen across a range of different antidepressants. So you can see here a positive biasing effect in this emotional memory task with reboxetine, citalopram, and mirtazapine, which are all antidepressants but work through different or slightly different neurochemical mechanisms. And actually you can see very similar pattern in a rodent affective memory test as well. And this is the affective memory test developed by Emma Robinson in Bristol, where she's also described similar positive biasing effects that occur very early on in treatment with these antidepressants. And so we think that this rodent model taps into something a bit similar to the human model, but it looks a bit different in terms of the method. And so I briefly mention it because it becomes relevant to what I'll talk about later. And so in her paradigm, I don't know if she's given a talk in this series. She probably have, I know that she has given talks in Oxford a few times over the last few years, so you may have heard of it. So you have a cute rat like that, and on one day they're presented with a dish with a substrate in it like coloured beads, and under the substrate is a sucrose pellet, which the rat quickly finds and consumes. And then on the other day, they have a different dish with a different substrate, in this case plastic rods, and there's also sucrose pellet in there. But on one of these days, the rat's been pre-treated with an antidepressant, and on the other with a vehicle or a sham treatment. And then on the preference day, they're presented with both, and the rat makes a choice. So both of these substrates have been associated with one sucrose pellet. So the reward value should be the same, but there's a tendency for the rat to select the substrate that was experienced when they were taking the antidepressant. So the antidepressant has positively biased the memory of this association. And we can also see in both the human and the rodent models that drugs that can induce depression as a side effect, such as this CB1 antagonist rimonabant, can induce the opposite pattern, a negative bias in affective memory. So this suggests that there are early effects of antidepressants if you measure them in this kind of framework, looking at memory and processing of information. And we've suggested then that these early changes may be critical for what happens later, for the therapeutic effects as they emerge over repeated weeks and months of treatment. And so if this is true, we would expect these two things to be associated with one another, that the patients who show the largest improvement in emotional bias may be the ones who then go on and respond to the antidepressant. And this is quite an important question because there's huge variability in response to an antidepressant, but we've no way of predicting who's most likely to benefit. So again, to go back to some of the original data, here we gave antidepressant treatment, either reboxetine or citalopram, over 6 weeks, which allowed us to see who was responding by the end of treatment. And what we're interested in is whether this early change in processing happy faces was associated with this later clinical response. And we found that it was, that those patients who had the biggest improvement in happy face recognition were also the ones who tended to do better clinically after the full 6 weeks of treatment. And it explains a reasonable proportion of the variance. It suggests it may be one of the factors that's involved in this antidepressant drug response. And this finding has been replicated independently a few times. And there's also this really nice paper by Shiroma, which suggests that this early change in positive bias with antidepressant is linked to clinical response, but we also need to have a look at the individual's environment as well. So if we think about the model, we would expect that if you change a bias and then you learn about this through interactions with your environment, and this culminates in clinical response, that the quality of your environment may moderate this association. And that's exactly what they found, that what is best is if you have a positive bias with the antidepressant and a supportive environment. And this is a particularly powerful combination. So just to summarize so far, antidepressants affect how we see the world, how we process information relatively quickly, even though we may not be aware of these changes at a conscious level. But we think that these set the scene for what happens later in terms of the clinical response through interactions with the environment. And so we've also used this kind of framework to look at understanding how antidepressants may work at the level of the brain. And there's quite a lot of literature already looking at the neural basis of this negative bias in depression. And I've just included here some of the kinds of review and formulations of this negative bias. But most of the models involve a diagram that looks a little bit like this. And that is that there's evidence that when people are depressed, areas like the amygdala, which are really important for directing attention to salient stimuli in the environment and the behavioural response to these stimuli, show an overactive pattern of response to negative information. And then areas up here, that, like the dorsolateral prefrontal cortex and the medial prefrontal cortex, tend to be under-engaged during this process. And these are normally the areas that would play a role in inhibition, contextualization, regulation. And so the idea is that negative bias may come about in depression because of an imbalance in this kind of circuitry. There's too much signaling saying these negative things are really important, pay attention to it, and not enough contextualization or regulation of that response. And there's also evidence that treatments, effective treatments for depression, can have effects on this circuitry. This is a meta-analysis that was published by Camilla Nord in Cambridge. And it provides evidence for this often cited view that antidepressants work in a bottom-up way and psychological treatment works in a top-down way. And so collecting together the studies in meta-analysis, looking at the effects of antidepressants in fMRI paradigms, and then again in psychotherapy, and comparing them, she found that it was particularly the amygdala that was affected by antidepressant drug treatment. It was reduced activation to negative stimuli, but it was more often the medial prefrontal cortex that was engaged with psychotherapy. So it suggests that there may be different treatments that may be effective, that can impinge on the same framework or the same circuits, but at a different loci. Although I think we do need more head-to-head comparisons of these different treatments, because if you compare the studies that were brought together in these kind of meta-analyses, they do tend to have very different types of psychological tasks that were used in the scanner, and duration of treatment and so on. So they've kind of evolved separately, and it's quite hard to compare them directly, but could be relevant to do more direct comparisons. And so thinking about the effects of antidepressants at the level of the amygdala, we can also see these effects very quickly. So this is a study with Bielsa in Oxford, where we presented quite simple fMRI paradigm with fearful and happy faces in blocks in depressed people, and in, oh, I've got these the wrong way around. No, in depressed people and the healthy controls. And you can see the observation that I mentioned, that when people are depressed, they tend to show this overactivation of areas like the amygdala compared to the healthy control group. And this is what happens with 1 week of an SSRI treatment. This is escitalopram. And you can see here, compared to placebo, in light blue, there's quite a large decrease in the amygdala interest in these negative stimuli. But the interesting thing, I think, again, is that these patients still felt depressed. They were actually on rating scales as depressed as the placebo group still. But there's already these changes in how the brain is reacting to emotional information. And so again, we can ask, are these changes fundamental to what happens later? Are they associated with later clinical response? And again, Bielsa followed this up in this study where she gave escitalopram over a 6-week period, which allows us to see whether people are responding or not to the antidepressant treatment. And the fMRI scan was collected at baseline and after 1 week. And what we're interested in is whether the change here early on in treatment was different in those who went on to respond versus those who didn't respond to treatment. And so everyone in this study was taking escitalopram. So the only comparison is about whether it worked or not later on in treatment. And we saw a network of effects here that were different early on in treatment with those who went on to respond compared to those who didn't respond, in interesting areas, I think, such as the amygdala, the thalamus, the insula, the anterior cingulate. And the direction of the effect was the same across the circuit, and I show it here for the amygdala, but it's really only the later responders that show this reduction in amygdala reactivity to fearful versus happy faces. Even though everyone was taking escitalopram, it seems to be more profound in those who go on and show a clinical response to the treatment. Again, suggesting that these early changes may be important in the clinical outcome, which takes weeks or longer to evolve. And so moving on to some of our more recent data, this was a study that we completed during the COVID lockdown, where we were looking at the effects of psychological treatments on these same kinds of measures of emotional processing. And this has been long in our mind as a kind of unanswered question, but this work really came from the psychological literature, and we'd seen effects of antidepressants, but we weren't sure of the nature and timing of effects of psychological treatments using the same framework in a psychological intervention. And so here we looked at the effect of behavioural activation, which is commonly referred to as a low intensity psychological treatment, which is focused on daily behaviour, where the proportion of pleasurable activities is enhanced in using a routine and trying to avoid procrastination. And so this was actually a study that we were about to start in the lab when the COVID pandemic hit. So we had to very quickly decide what we were going to do with this study. And so we decided to put it all online and do this psychological intervention remotely, and to collect our task data remotely as well, but with individual people that we'd had a lot of contact with. And this was part of Teresa Brazakova's DPhil work. And so this is the design. We recruited people who were mild to moderately depressed. They received behavioural activation just for 4 weeks or wait list. And we took clinical measurements going up to 4 weeks after the end of treatment. And we also used these emotional processing measures. And I think we had two main questions, partly because of having to redo this study rapidly. We didn't know, first of all, if behavioural activation would even be effective in this kind of context. There's a lot of evidence that behavioural activation is effective under normal circumstances, but this was during the most extreme phase of lockdown, where opportunity for behavioural change was limited. So we weren't 100% sure what would happen. And then the second question, which is what we started off wanting to look at, is if this is effective, how does it change emotional processing? And so in answer to the first question, we found that luckily behavioural activation was still effective under this condition. You can see here in red the group who received behavioural activation compared to the wait list. And so it's quite a rapid and sustained response in terms of depression, anhedonia and anxiety, which is still evident at, or even better in the case of depression, at the 8-week follow-up. So even during lockdown and the COVID pandemic, it seems that there's still something to learn from this, this behavioural activation approach. And then we looked at the emotional processing using our task battery, which we put online. And this shows the change in recognition of negative faces from baseline at week 2 and at week 4. And certainly by week 2, there was evidence that the participants who'd received their behavioural activation showed a greater reduction in recognition of these negative faces compared to those in the waitlist condition, which was less clear at week 2. And then we looked to see, well, how are they seeing these negative faces then? Are they just confusing one negative face with another, which would seem less useful? But in fact, what they were doing was they were seeing these negative faces instead as more positive. And so there was a true shift in seeing negative to positive with this psychological intervention. But perhaps it occurs a little bit later than what we would see with antidepressant drug treatment. And perhaps that's also consistent with this Camilla Nord's data, which I mentioned a few slides ago, looking at this top-down versus bottom-up effect. So these effects have been seen in our lab-based studies. I think they're mechanistically interesting. They've certainly given us a lot to do over the last years. But fundamentally, what we want to do is to use this information to somehow improve the treatment of depression. And so in the second part, I'd like to focus more on the clinical implications. And I think that there are a number of clinical implications from this kind of perspective. I think the first one is that this kind of approach work has suggested with people with lived experience of depression and our patient advisory groups, that it seems to make more sense as a way of understanding treatment and looking out for effects that you might be experiencing. I think everyone understands negative biases. We've all had situations where we've experienced this kind of negative bias. And so it gives a kind of language and understanding of antidepressants that is more amenable than talking about serotonin or cells or synapses. Another way in which we've used it, particularly in work led by Michael Browning together with Pivotal, is whether we can actually embed some of these measures into the clinic and use them at an individual level to tell if somebody's not really responding to antidepressant medication. And if we could detect that, for example, after a week, rather than waiting 6 weeks, we might be able to escalate treatment for those individuals and lead to a better outcome. And there is evidence in this PREDICT study that was run in almost 1,000 people across Europe that if you adjust treatment based on this emotion processing response, you can facilitate symptoms, particularly anxiety, and also improve function, although there was less effect on the symptoms of depression itself. But I'm going to focus on this last one. Can we use these measures as a kind of human model to try and improve the way in which we develop new treatments? So developing new treatments in psychiatry is really, really difficult. Over 90% of new treatments will fail before they're licensed. And part of the problem is that we just don't know which treatments to invest in. You have to put an awful lot of money and time to do a randomized clinical trial. It can take literally billions of pounds and many years. And at the end of the day, most of these treatments won't even work. And so we wondered whether we could use these kinds of lab-based measures as a way of looking at new compounds, trying to understand how they might be working, and at which dose and at which individuals that might optimize this decision-making for their clinical translation. And we work both with pharmaceutical industry partners who mainly hold these novel treatments that we're interested in, but we also use a repurposing strategy, which is looking in other areas of medicine to see if there's any other medicines that might have shared mechanisms that are already licensed that we might be able to use. And this is a very useful strategy because it speeds up the whole process, because we already know that they're safe and can be prescribed in humans. And so we started to think a lot about statins, which are, of course, a very widely prescribed treatment for high levels of cholesterol, have a lipid-lowering mechanism in the liver, but they also seem to have effects on brain function and action as well, and particularly a lot of effects which seem really, really appealing to somebody working in the field of depression. They have central anti-inflammatory effects, they have effects on neuroplasticity, and they also affect monoamine function as well. And so they seem like an interesting candidate. We know that they're safe and can be easily prescribed, but could they work in depression? And there is some data from looking at databases of people who are taking statins who seem to have lower levels of depression, but the data is a bit mixed in these studies, as well as in some small scale randomized clinical trials. And so we wanted to look at this a little bit more detail. But again, we were struck down by the pandemic and all our studies had to stop. And so we had to come up with a different design, which, as you'll see, has both advantages and disadvantages compared to how we normally run our study. And so we did a kind of emulated experimental medicine study looking at epidemiological data that we collected across time in our COSY study. So we initiated this actually very quickly in response to the pandemic, and we followed up people across time. Particularly, we quickly launched this phase 4 follow-up because this was at a time of added restrictions, kind of unexpected added restrictions, which led to a dip in mood and increase in depression and anxiety for many people. And one of the advantages of doing a study like this is, of course, we had loads of data, over 2,000 people, which we'd never have in our everyday studies. And we were also able to recruit from across the UK, and the demographics of the people who took part in the study were more representative of the UK population than the people that we normally have coming into our studies. So in that sense, it was really useful. And it also allowed us to test out some hypotheses in this large data set that we wouldn't have been able to test out in our small scale studies. So sorry to reintroduce a trauma signal for many of you. This was looking at the follow-up data. As I mentioned, this was when the restrictions were reintroduced and we're all feeling pretty miserable. So we decided to quickly put out some follow-up data. And what we're interested in here is whether the negative bias measured at the start of the pandemic would predict how people reacted to this stressful situation, this additional lockdown in terms of mood and anxiety. And we found, as we would expect, that the individuals with a high negative bias, here in red, were more likely to show an increase in both depression and anxiety in response to this stressful additional lockdown. So it's, again, evidence of this bias by environment interaction. So this, I think, is a kind of useful reality check to the integrity of the data. But what we were mainly interested in here was looking at people who were taking statins versus people who weren't taking statins. And as a control, we looked at a similar risk group, people who were taking another type of cardiovascular medicine, an antihypertensive, or both together. And we didn't expect the antihypertensive medication to affect negative bias, but we thought it would be a useful way of trying to think of some of the other confounds that would occur in this kind of data collection. And we also tried to control for these statistically as well, as much as we could. What we found, which was consistent with our hypothesis, was that if you look at facial expression recognition across emotions, that if you're taking a statin, you are less good at recognising negative faces of anger and of fear. And this was true in the individuals who were taking both types of medication, but it wasn't seen in the individuals just taking a antihypertensive. So this suggests there may be a kind of lower risk factor for depression. We also used another measure of reward and loss learning using probabilistic instrumental learning task. You see these two kinds of stimuli, and one is associated with a higher probability of reward than the other, or a higher probability of loss. And gradually over trials, you learn to select the most advantageous stimulus or to avoid the least advantageous stimulus. And here, with those who were taking the statin, there was no difference in the ability to learn about reward, but the statin group were less sensitive to loss, which is actually opposite to what you'd see in depression, and also particularly opposite to what you'd see if you induced inflammation in healthy volunteers, for example, with giving a drug like alpha interferon or a vaccine, for example. You would often see the opposite effect to this. So this was interesting, in line with the anti-inflammatory properties of statins. And there was no difference in general memory, for example, in the NVAC task, absolutely similar to if you're taking a statin compared to not, which was reassuring because actually participants often complain about brain fog when they're taking statins, but this shows that there was kind of no general changes in cognition, although there were in the group who was taking the antihypertensives. They were a little bit less good on this measure. And so I think we learned a lot from doing this. As you can see, there are pros and cons. We had a good amount of data. We were able to evaluate a hypothesis. Of course, it's when you're not in control of who gets the treatment, there are many confounds that you have to think about. But I think this was enough for us to start a new study where we randomized people taking statins versus placebo across people who were at risk of depression. But using this online experimental platform that we'd set up very rapidly because of the COVID pandemic was actually a real advantage here. But because statins are relatively safe and easy to take, we could do this study remotely. We could do our interviews remotely, collect the data remotely, and we could post out statins and placebo to people to take part. And so again, we were able to take advantage of this broader UK group, even when we're looking at an experimental medicine study. And this is a study that's still in progress. And so I can't really talk about antidepressant drug treatment and action without mentioning the interest in fast-acting antidepressants. We're very used to this idea that antidepressants have to take a number of weeks before you see any effects, but there's this new wave of new treatments or repurposed treatments in a way that seem to have a faster onset of action, such as dissociative agents like ketamine and psychedelics like the key ingredient of magic mushrooms. I really like this picture, this image here of, it was from a Guardian article describing a ketamine experience. I think this is the S-ketamine nasal spray, which is administered like this. And this quote from the patient who took it, it was like a spring breeze had blown through my head, which I thought sounded very vivid and compelling description of taking this S-ketamine. And so interest in ketamine has been kind of rumbling along for the last 20 years or so. It was described in 2000 to have these very rapid antidepressant drug effects. And this is the original publication, just to show that this is a drop in depression across time. And you can see that the drop in depression compared to placebo occurs very rapidly here in 3 hours and persists. In this case to 72 hours, and it's probably a few days longer than that. And this is distinct from the high that you might get from ketamine and the dissociation as well. These effects have kind of died down by the time the antidepressant drug effects work. And so this has been labelled as the most important discovery in half a century in depression research. And I think this is just because it's opened our eyes to the possibility that we don't need to always be giving an SSRI or a serotonin agent that takes weeks and months to work, but perhaps there is hope that we could find some treatment that might have a quicker onset of action like this. One of the problems with ketamine is, though, that the effects, although they persist even after the drug has left the system, these clinical effects do die away after 5 to 7 days, and so then the treatment is often repeated. But again, this poses some questions for our mechanistic models. How do these fast effects even come about? If we think that this interaction between your emotional processing bias and the environment is so important, how do these effects kick in? And I think Emma Robinson's work really shines a light on this. And she's got this affective bias test that I mentioned, and she can use it in 2 different ways. We're looking at encoding, where treatment's given at the same time as the experience, but also a different variant where the drug is given at retrieval, just before the preference test, when a negative bias has already been induced in this test, either with a drug or stress. And she finds this really interesting double dissociation that conventional treatment like venlafaxine and serotonin, noradrenaline, the uptake inhibitor, has a positive bias in encoding but no effect on retrieval. And ketamine has the opposite. It reduces negative bias in retrieval but doesn't affect encoding. And she suggests that this could actually play into the timeline of these clinical effects, because if you affect encoding, you need to experience your environment in interaction with your bias in order to learn from it and gradually feel better. But if you can go back in time and rewrite or rethink about your memories from the past, perhaps you don't need this new experience and the effects could occur more rapidly. But because there are no effects on encoding, any new information would still be encoded in a negative way, leading to the effects reducing across time. And so there's really nice evidence for this in preclinical animal models, and we're looking in humans at the moment in 2 studies, both in healthy people and in treatment-resistant patients, whether the same kind of difference between encoding and retrieval of emotional memory can be seen in humans as well. And if so, I think this would be a really nice way of refining our models of antidepressant drug action, thinking about what kinds of clinical effects we're most likely to see given different profiles in these kinds of measures. It's also interested in the psychedelics, like psilocybin, which is one of the core ingredients of magic mushrooms. And this is a study that was published just a few months ago by Compass Pathways by Goodwin, which found a dose-dependent effect of psilocybin on depression severity in treatment-resistant depressed patients. And so there were the largest effects with the 25 milligram dose compared to 1 milligram control, all given with psychological support. And one of the interesting parts of this observation was that the effects are both rapid, they occur within hours, but they also seem to be sustained, that they last for weeks. So it's a little bit different from what the literature says about ketamine. But there is a big problem with trials like this, as we're all aware, and as Guy Goodwin himself points out in this editorial. Psychedelic experience is almost by definition even necessarily unblinding. And this is true of the ketamine studies as well. You know if you're having a psychedelic experience, you know if you've had a dissociative treatment, and then you are asked to indicate how you feel on a self-rating questionnaire or clinical interview. So there's a huge potential problem here of functional unblinding. And that's why these mechanistic studies, I think, are so important, because they suggest that the effects may be real outside of looking at placebo effects or expectation effects across time. And Emma Robinson's let me use her slide here, unpublished data looking at psilocybin in a study with Compass in these 2 ways of looking at affective memory, where she finds that psilocybin has effects on negative bias retrieval. It reduces negative bias retrieval, like ketamine, but it also increases positive bias acquisition, like venlafaxine. So it seems like the clinical effects to have these features both of sustained and rapid-acting antidepressant drug treatment. There's much less data in humans using the same framework, but we did get the opportunity to collaborate on this study. There was a study run by Robin Carhart-Harris, and in this study, they gave participants either escitalopram for 6 weeks or 2 doses of psilocybin over the same period. And we use the same measures of affective bias before treatment and at the end at 6 weeks. And what we found was the escitalopram, as we would expect, reduced negative face recognition compared to positive, and reduced negative misclassifications compared to positive. And the same profile was seen in psilocybin, even though this was just 2 doses over this 6-week period. So this is the paradigm, I think, which is most similar to Emma Robinson's encoding part, the new information processing. And so we would expect these 2 drugs to have very similar effects. What we really need to look at now is if we see effects on the retrieval of negative memory as well. Certainly that's what people tell you when they've had this kind of psychedelic experience, that reprocessing past trauma, past memories has been really important, thinking about these in a different perspective. But what would be really interesting is to look at this in the same kind of experimental medicine models to see if the effects are comparable. So conventional antidepressants affect neuroinformation processing, and this is consistent with a relatively slow onset of action. Drugs with a faster onset of action affect retrieval, and then psilocybin seems to do both, but this work needs to be translated to human studies as well. And so just to conclude, I guess broadly speaking, I focus very much on psychological effects of pharmacological treatments, and this, I think, can help us take a different perspective on how the treatments work, why they may work, why they may not work that well for some people or under some circumstances. And I've also talked about how we can use this partly as a way of screening and understanding new treatments, and particularly in this new wave of thinking about antidepressant drug action with drugs that might have very profound subjective effects. It allows us to uncover mechanisms separate from this functional unblinding. And I suppose the biggest message that I'm always advocating is that it's really useful if we can think about treatments in the same framework rather than thinking about them separately. If we think about them together, we might be able to formulate ways in which they could actually benefit each other more effectively. So I just end by thanking everyone in my group in Oxford, the Psychopharmacology and Emotion Research Lab, or PERL, and also my long-term collaborators since those early days of acute manic patients with Phil Cowan and Guy Goodwin. Thank you.
Thank you so much, Cass, for a brilliant whistle-stop tour of things antidepressants and fast-acting antidepressants. Brilliant. I'm sure there will be questions from the audience, and I'm also trying to keep an eye on the chat. So if there's people online, of which we have quite a few, please feel free to either raise your hand or post your question in the chat, and I will read it out. First from the room, especially if there's any junior people who have questions, we always like to give you a chance to ask your question first. Yes. Ingrid.
Yeah, so I want to ask about the Robinson's affective bias test. So did the animals only learn about substrates that were associated with food?
Yes, in that version of the yes, it is always about food reward. Yes.
So how do we know if they were showing a sensitivity to emotionally laden stimuli in general, like both negatively valenced and positive valenced, rather than just specifically the positive bias?
Yeah, she has done a lot of controls just to show it's not like a general effect on memory or locomotion, or and she's done the way that she does the negative bias is that she pairs one of the substrates with a negative experience, like being constrained or restraint stress. So then you can see that the animal avoids that, but it's still embedded within the reward judgment of the two associated substrates.
Yeah, but I wonder if it would be better if the animals also learn about punishment, or like if you incorporate another version where they do like peer conditioning, and then you assess the effects of drug on both peer learning and reward learning, and see if it's a general effect or an effect specific to reward learning.
Yeah, I think it's tapping into something a little bit different. So if you look at the effect of the drug on fear association learning, it's more the kind of memory of that association, I think, that you'd have to try and design an experiment to get at. But you're right. I think you're only looking at half of the you're only looking at positive emotional processing when you do it in this way. It's true, but you would have to think about how to do it in an equivalent way for negative stimuli.
Yeah, thank you for your help. I was just wondering, so we know that antidepressants work and that CBT and therapy work, but sometimes they also work together and we combine them. And I was looking at some papers that the psychotherapy that worked promoting exposure therapy outcomes. But there's also some evidence for SSRIs working against cognitive bias modification, and I'm not sure, is there any new evidence on that? Did you comment on why that might happen?
Yeah, I think it's really important question, and it's something that actually the behavioural activation study that we set up was designed to evolve into. And so the reason that we were particularly interested in behavioural activation was because if you think about antidepressant drug action affecting biases, you could end up in a situation where perhaps you're not making the most of that if you're not engaging with your social and emotional context. And so one reason why they might not work that well, even if the emotional bias has changed, is because you're not having that opportunity to learn from it. And so we thought that perhaps behavioural activation and antidepressants together might be a really good combination, because you get the positive biasing effect of antidepressants coupled with the exposure and learning from the behavioural activation. And that study that we're doing exactly that is being run at the moment in our group, looking at the combination and seeing whether that is facilitated versus different. You're right, it's not always positive, the combination. I think that's why we need to understand what aspects we're really expecting to be affected by the different treatments before we put them together. And perhaps it's with the cognitive bias modification, as you say, perhaps putting two treatments together that are doing the same thing is not so valuable as putting together a treatment that does one thing and then the translation of that is a way of facilitating it. But yeah, it's a really good question, because we do need to figure it out.
I think we'll alternate between, there's a couple of questions on the chat, so we'll just alternate between the rooms. So there's one from the chat that is asking, do you think psilocybin might replace current antidepressants at some point, or do you think some people might still benefit more from SSRIs?
Oh, that's a good question. I think the way I usually think about antidepressants is that the more options you have, the better. And it's not that I think that one thing will take over and the rest will kind of die away, but more that we might be in a position to best tailor treatments for individual people. And I think not everyone would want to do the psychedelic experience. I think by all accounts it's quite hard work and something that not everyone would want to do, and SSRIs are pretty good effective treatments, but they're also not suitable for everybody. So I guess what I would like to see is having more options and a better understanding of who would benefit from which option across time. I mean, I'm not sure what I would choose. I think it's pros and cons of all the different treatments.
Okay, we've got a couple more in the room. Yeah.
Yeah, on that point of individual differences, seems like your model is very convincing in that it can explain how the fast-acting antidepressants and the slow-acting how they kind of tap into different mechanisms. I was wondering, because these fast-acting antidepressants have mostly been tested in people who are treatment resistant.
Yeah.
So by definition, for them, the kind of the encoding part didn't work. So do we have any evidence or other measures about these patients that would support the idea that in some patients, the encoding part would be the better target, and in other patients it would be the retrieval? And why would that be?
Yeah, I don't think we do have any evidence to pull those things apart. You're right that most of the fast-acting treatments have been developed with the treatment-resistant group in mind as a kind of second stage or third stage treatment option. I think that there are potential differences between the treatment-resistant depressed patients who don't respond, but it hasn't really been looked at in this framework. It's usually looked at, for example, with the inflammatory perspective, but that I mentioned can also be important for some patients with depression. So why would it be? I suppose it could be, for example, if past memories were very important in a particular case of depression, which will be varied across individuals. It may be not enough to have positive things coming in and fresh if you've still got the weight of what's happened to you in the past, but whereas for other people it might be very much how you're feeling right there and then in interaction with things going on. So I guess you could imagine why it would be different for different individuals, but it hasn't. This has really only been looked at in a lot of detail in animal models, and hopefully we'll have the data, a bit more data in humans going forward. Yeah.
Following on from this, I was wondering whether today I presume there hasn't been work on this yet, but whether one could look at specific both genetic and environmental factors, for example, whether having the short allele of the TP5 gene has implications for which treatments are most likely to work, or whether the extent of negative life events at the extreme, I suppose PTSD associations, what type of treatments?
Yeah. There have been studies trying to look at that with mixed results. In general, the work on the genetic predispositions has often been a bit underpowered for the effect sizes that you would like to see. And I think that probably is correct to say that there aren't really any strong associations at the that we know about at the moment between those polymorphisms and treatment response. And if there are, they're quite subtle and not enough to actually define if an individual in front of you would benefit from one type of treatment versus another. But I think as we understand more about these mechanisms, it might be that looking at an individual's predisposition at a cognitive level may be closer to the experience of the symptoms and the treatment. So it might be a way of, because you can arrive at a negative bias or problems with negative memory through all kinds of routes. Could be partly genetic, could be environmental, could be that you've got an undiagnosed inflammatory disease. It could be all kinds of things, and perhaps it doesn't matter from a treatment perspective how you get there, but what the common overlap is that might be targeted with different types of treatment. So hopefully this kind of approach could help refine some of those questions.
I'll read one more out from the chat, which David Bannerman is asking, what's the relationship between the early changes in emotional bias seen with SSRIs and the acute increase in anxiety that patients often report when first taking the drug?
Yeah, that's it's a bit of a mystery. So sometimes with SSRIs, if we look at, it seems to interact with the trait characteristic of the sample. So we can see increases sometimes very early on with SSRIs in terms of fear reactivity and fear recognition that very quickly reverse across time. But they tend to be seen in studies where we have more anxious participants to start with, so it kind of interacts with your individual predisposition as well. But in terms of the relationship, I think if anything, those effects limit the benefit of the positive effects rather than them being somehow in concert. Yeah.
There were two more in the room, I think, Johannes, and then over there.
So this is my question to Lillian about, in your case, the responders and non-responders. So it seems to be that the case that people who respond to SSRI are the ones who show this early effects on this emotional face recognition task. So is it also that the other ones who do not do that, they don't show this spike to begin with? Or so now you're using something that's week 1 to predict what's going to happen at week 8, but would you also be using week 0?
Yeah, that would be ideal, because it would be really nice to look at people before they've had any treatment and look at the bias and see which treatment might be best, even at that time point. We haven't had any success in finding any link between baseline negative bias and the effects of these conventional antidepressants. I think it may be that if you used a huge database that we haven't got, that you might be able to see some association, but certainly you don't, the change seems a much more sensitive predictor of clinical response than the baseline, which, I guess it suggests, because that change also picks up a lot of things you wouldn't necessarily just get from the baseline measure. So, for example, if you're a kind of ultra-fast metabolizer of the drug, you might have a negative bias at baseline, but that drug's not actually doing anything for you specifically. You'd see that in the change, but you wouldn't be able to tell that from the baseline. So there's all kind of, it captures lots of.
I guess it's like a subgroup of depression that responds to SRIs, and those are the ones who have this emotional bias, but they're sort of also present in other people who are drug resistant.
Yeah, it seems to be, it's not really at least in our hands, the presence or absence of the negative bias at baseline, but whether you're able to shift it with the antidepressant. But it is, yeah, that would be the kind of gold standard outcome that we'd like to achieve, is looking at people at baseline and seeing which treatment might be most suitable. But either we haven't got the right measures, or they're not sensitive enough, or we haven't got the large scale data to actually see it. But we don't, sadly.
One person online is asking if the slides will be available, and that I can answer that. The talk was recorded and will be on the website. So I think for looking up references, someone was asking.
Sure.
So I think you should be able, that's Helen asking. And then I think we had one other question there. Yes.
Do you have any hunches about the mechanisms behind these changes to emotional bias? And for example, if it was anything to do with affective connectivity, how do you think that, like, the trials are also ongoing to see if you can find a drug that maybe disconnect the hallucinatory properties of psychedelics or depression, and whether you think they're going to be effective or not? Because will it be things? Will it sort of be?
Yeah, it's a key question. And I guess from a drug developer's perspective, it would be really nice if you could harness the power of the 5-HT2A agonism in a way that didn't lead to the psychedelic experience per se. I'm not sure I know enough about, I don't think anyone knows the answer to that, and I'm not sure I even have a really strong opinion. I think it is important, though, that there's some kind of processing change going on, which may be part and parcel of this psychedelic experience or the dissociative experience, because there's some recent data that was presented at a conference that if you gave ketamine as part of anesthesia in people who are depressed, you didn't actually show any therapeutic effect. And I think if you're asleep, then you're probably not reprocessing your memories, and perhaps it is that kind of active processing, thinking about things from your past and reconsolidating them, that may be really important. That might be kind of the nature of that subjective effect. And so I guess I kind of think that they might be a bit closely linked, but whether it's possible to kind of boost one while kind of minimizing the experience, I think that we'll have to see. And I know that it's a kind of key topic for many drug companies to think about whether they can do that either with very low doses or different types of compounds as well. So.
Okay, let's thank Kath again for a fascinating talk.